Next, we have Lauren and Caroline talking about how to use program logic and co-design for the planning and the implementation of health interventions. Over to you two.
Hi everyone. I'm Lauren. I'm a research assistant at Mind Australia.
And I'm Carolyn. I'm the Participation and Co-Design Manager at Mind Australia and bring family care lived experience to that role.
And today we're going to talk to you about using program logic and co-design for planning and implementing a specific suite of physical health resources at Mind Australia. But before we get into that, I'll just say Mind acknowledges that Aboriginal and Torres Strait Islander peoples are the traditional custodians of the land on which we work, and we pay our respects to elders past and present. We recognise the intergenerational impact of the history of invasion, dispossession and colonisation, and are committed to the recognition, respect, inclusion and well-being of Australia's First Peoples.
Mind also values the experience and contribution of people from all cultures, genders, sexualities, bodies, abilities, spiritualities, ages and backgrounds, and we're committed to inclusion for all our clients, families and carers, employers and volunteers. And that's particularly important to remember when we're thinking about physical health. We also value the expertise and leadership of people with personal lived and living experience of mental health challenges and alcohol and other drug use, and families and carers as we work together to influence and transform the services and systems in which we work. So for those of you who aren't familiar with Mind Australia, Mind is a community managed mental health organisation that operates in 4 states in Australia, so Queensland, Victoria, South Australia and Western Australia, and we're about to commence service delivery in New South Wales in the near future. So we support people facing mental health challenges and wellbeing concerns, and we provide support to offer them help, hope and purpose in their lives. So we really focus on kind of tailoring supports to individual people and making sure that what we do is evidence informed. So we've provided recovery support to over 11,000 people in the last year. So we're committed to lived experience approaches and making sure that the people who use our services, whether they're clients or whether they're families and carers, have a say in decision making and are involved in that continuous improvement in practice over time. So we strive for meaningful participation with clients, carers and families to co-design processes and challenge biases, recognising some of the challenges in doing co-design. So last time at the Equally Well Symposium in the Gold Coast, I gave a presentation about a physical health tool that we had co-designed with our lived experience advisory team. So this was a co-design of a resource that already existed. So we had a physical health checklist that was based on questions that came from national guidelines. So we reviewed that checklist and got feedback from the clients who use our services and also our staff members, and found that there were some problems with that tool. So we went through a process of working with our lived experience advisory team to kind of workshop what the issues were and what the priorities for designing a tool would be. Then we presented that information to our community mental health practitioners, and we did a survey and a workshop to gather their perspectives. And then we reviewed the current guidelines and literature just to see kind of how the field had moved on since the original checklist was designed. Then we went back to the lived experience advisory team and we did another survey and a workshop to look at how we could bring together all of that information. And then we drafted a tool, so came up in using co-design language, came up with a prototype that we then brought back to the community mental health practitioners, and then they kind of looked at how that would work for them in practice, and we tweaked the tool to make sure that it would work in a practical sense with clients. And we also got feedback from content experts as well into some of the questions and areas, recognising that there's some nuance to this work, so particularly around eating disorders and asking questions about food and nutrition and physical activity. So this was our toolkit that we designed. So we came up with a practice guideline which goes through all of the principles that underpin the practice tools. We have a My Physical Health conversation starter. So this is an opportunity for people to choose the areas that they want to talk with their worker about, and some prompts about why those particular areas are important. And then when people, they might choose to talk about kind of sexual and reproductive health, for example, to take from Debbie's talk this morning, or they might want to talk about sleep. So they can choose those topics, and then the other pages have some questions to ask about. Then we have, if people want to set a goal around or take some action around their physical health, then we have a resource called Ideas to Explore When Setting a Goal. So these were some of the ideas that our Lived Experience Advisory team came up with about the practical ways that of things that they can do themselves or things that their worker can help them with to support their physical health. We also created an intranet page to kind of bring all of this information together, because it was really kind of rich content that we'd heard through the workshops and surveys. And most recently, we've been creating a webinar for staff about how to have supportive conversations about physical health, recognising that physical health can be a sensitive topic for people. So we have some video interviews and things that we've from our Lived Experience Advisory team that we've pulled into that webinar. And it explains all of the principles in much more detail and why they're important. So in relation to implementing the toolkit in practice, we've been kind of going through this process of implementation for the last 18 months or so. So we've prepared resources for service managers and team leaders to introduce the tool and toolkit. We've done tailored presentations to team members. We've done the online webinars, and we've also kind of encouraged quality improvement activities as well, and looking at kind of measuring progress using data from client records, which Lauren will talk some more about.
So essentially from this point, we wanted to work out how to evaluate whether these resources were having an impact. So we worked with, the research team worked with Carolyn and Clara, a peer cadet, to come up with some evaluation questions, which were: do the resources support staff to have conversations with clients about their physical health? And do the resources enable clients to set goals and receive support for their physical health needs? So these evaluation questions helped guide the development of a program logic, which I'll talk you through now. So a program logic in this context is referring to understanding the theory of a program. So what activities are leading to which desired outcome, and what are the stepping stones between those two things. So I'll kind of talk you through the process now. So first up, we mapped out what the activities were, and I broke these down into the what and the how. So the what refers to the tool itself, the intranet page, the practice guidelines, the tip sheet for conversation starters, the webinar, PowerPoint slides for service managers, and then the how are the channels of communication to get that out to staff members. And then we have immediate outcomes, which are if staff engage with these tools, what do we expect the outcome to be from that? And we are predicting that it will lead to an increase in knowledge, skills, confidence to have those conversations, those supportive conversations with staff about their physical health, and lead to an increased intention to use the tool. And following that, we have intermediate outcomes, which we think through engaging with these resources, building knowledge, skills, confidence and intention to use the tool, that it will result in an increased offer and increased uptake of the tool in practice. And then leading to our intended outcomes, which are kind of those larger desired changes, which our staff feel comfortable to offer and use the tool as part of their routine and ongoing practice, and clients are able to set goals and receive support around their physical health. So you can see how there's kind of assumptions made at every point here, which are based on, behaviour change theories like, theory of planned behaviour, drawing on those, knowledge, skills and confidence being built will lead to increased offer, and, you can see how each is leading to the next thing. So from this point, we need to map the data sources to measure each of these outcomes so we can work out whether we're achieving what we're hoping to, and if we're not, at what point are we not achieving those outcomes. So that's what I'll talk through now. And this is all, I guess, within, a not-for-profit setting where there's not a lot of resourcing for elaborate research. So we're drawing on existing data to answer these evaluation questions. So if we first look at the immediate outcomes, which are those increases in staff knowledge, skills, confidence and intention, we're assessing those through a short survey among staff who have engaged with the tools. And that's through a survey provided at the end of an online webinar and distributed through email. So just a short survey to capture whether we're seeing those whether we're seeing high levels of knowledge, skills and confidence around having those conversations. Then for the intermediate outcomes, we're looking at increased offer and uptake of the tool from staff and among clients. So we're obtaining this through an audit of client records, and we're looking at what proportion of clients have a physical health tool completed pre and post implementation of the new co-design tool. So in 2019, when the old checklist was in place versus post implementation where the new co-design tool is in place. And we're planning on doing this for all client records that are available, but we're also doing a sub-analysis of residential services. As we know, there can be a high level of kind of comorbidities in those services, and with the kind of expanded service duration, sometimes it's more of an opportunity to implement some health promotion activities. And then lastly, for intended outcomes, this is about staff feeling comfortable to offer and use the tool as part of their ongoing practice, and clients are able to set goals and receive support. So there's two data sources going into kind of measuring these outcomes. The first is qualitative focus groups or interviews with staff and clients. And I think these are just some example measures we could be using, but I think it will be informed by some of the quantitative analysis we do as well. And then the second data source is an audit of My Better Life plan. So I think you might have briefly mentioned this. My Better Life is a goal-setting tool at Mind where clients can look at various life areas and choose which they might want to set some goals within. So from this, we can look at what proportion of goals that are set are focused on physical health. And again, looking at the time periods of pre and post implementation for all client records, and also looking at a sub-analysis of residential services. So that's, I guess, the plan, and we're yet to complete all of that, but we've pulled together some preliminary results just focusing on residential services. And so this analysis is just based on adults in long-term residential services. So these are supported independent living services, usually 12 months or more. And I looked at for what proportion of clients did they have a physical health checklist completed in 2021 compared to after the new co-design tool was implemented in 2022, for what proportion of clients had a physical health tool completed then. And you can see there's a slight increase. This is just preliminary. Once we do some more comprehensive analysis, we might find different trends, but it's good to see in the short term that we might be getting a slight increase in the use of the tool. And then we've also looked at, from that, we are kind of thinking that there's more conversations happening about physical health using this tool. But this result is looking at for how many people in this same service are then setting goals using a My Better Life plan around physical health. And so this is looking at the proportion of total goals that are focused on physical health, and it's about 1 in 4 for that same service type. I will point out though that for the same time period, looking at the number of physical health tools completed, there was about 150, whereas there's only 35 people then using the goal setting tool. So already we can see there might be a bit of a gap in people having a conversation about physical health and then going on to set goals or, take further action. And that might be because the conversation was sufficient and they received self-management strategies that are working for them, or it could be that they might be missing out on that further support, and that's while we'll be doing the qualitative analysis and the further data collection. And I also pulled the same data for other residential service types. So we've also got adult and youth short-term residential services, which are prevention and recovery centres, or step-up, step-down services, which are about 14 to 28 days in length, and also youth long-term residential services to see what proportion of goals set in those are focused on physical health. And you can see it's far lower than the adult long-term residential services. Which could be, particularly for the short-term services, it could be a result of those services partnering with clinical partners who might take on a more active role in the physical health management side of things with allied health professionals involved. But it is interesting, particularly in the youth long-term residential services, that the proportion is a lot lower, because obviously that's quite an opportunity to get in early with prevention with that type of care. So in summary, from those results, we might be seeing an increase in the use of the My Physical Health tool after redevelopment. Obviously, further analysis is needed to confirm that, but that's promising. Using the tool may not always lead to setting a specific goal around physical health, from looking at, that number of people engaging in a physical health conversation versus setting a goal. And that's, I guess, shows the importance of the program logic and being able to pull that out even at this stage. And goal setting around physical health may differ by service type. And then I'll pass to Carolyn to talk through our learning so far.
No worries. So the things that we've learned so far is that involving someone with lived experience of mental health and physical health challenges early on really helped to shape some relevant questions for our evaluation. And so we pretty much adopted all of those questions and the phrasing verbatim. So we didn't kind of make any changes there. So I think kind of one of the other lessons that we've learned is about the importance of collaboration among teams, and kind of using that shared expertise to problem solve. We'll be kind of speaking with the people, particularly in youth services as well, to kind of think to further understand whether the tool is meeting the needs of young people and whether it needs to be presented in a different way to better engage young people in those conversations. And also thinking about kind of how the environment is set up as well. So creating health promoting settings rather than relying on individuals to make goals for themselves. So that's something else that we can explore. And another kind of important lesson is about the use of existing data to evaluate knowledge translation. So through this the creation of the tool, we're effectively translating high-level policy guidance into a practical tool. And so, we can see how effective that is through this process.
Thank you.
We have time for one quick question.
Thank you for a beautiful presentation. I would like to ask, at what point in the care is this tool used? So is it part of your routine software that you use to assess patients, or is it an additional tool for the clinicians to use?
Yeah, that's
Thank
a
you.
great question. So it's offered at 2 different points. So if if someone kind of identifies that physical health is an area that they'd like to work on in their My Better Life plan, then they'll introduce the My Physical Health tool to have that conversation. And also the staff do like an assessment at the beginning of supporting a person just around what their issues are and looking at things like a safety plan and any potential risks. So if physical health conditions are identified as a risk, then we'll offer the physical health tool as well. So, so it's not mandatory, but it is offered a number of different ways for people. Yeah, so we've tried to kind of. Oh, yeah, sorry. So, the question was about how it's embedded into our software and data collection systems. So, we've had to work with our business team to get that happening. Lauren probably knows more about how that happens at the moment. At the moment, it's manual. So, like, it's a manual interactive PDF that people fill out and then they put it into the data management system. So, we're increasing in our levels of sophistication, but we're not fully integrated yet.
Thanks so much.
Thank you.